Good evening and welcome to everyone present here for today's session. The White Army is very excited to have Dr. Shivam Arora sir from MAMC as our mentor and teacher today. Welcome to you, sir.
Thank you.
I'd also like to extend a warm welcome to all the active members to this session. With the permission of our mentor, let's please begin the presentation.
Hello everyone. So today we'll talk on this topic, that is basics of echocardiography, and in this topic we'll discuss only about transthoracic views of echocardiography. So first of all, this is a probe that we use for doing this echo, and in adults we use this high or low frequency probe that is a 5 Hertz. We use high frequency probe as the cardiac system in pediatrics are superficial. Okay. Now the important thing about this USG probe is that we have this index mark here. We use this index mark in 2D echo to make different views. Okay. So the position of this index mark while making any view is quite important. Then the first view that we make is the parasternal long axis view. In this, we'll put the index mark at 10 o'clock position. So we are seeing here that this is the index mark. We'll put this probe, this is sternum. We'll put this probe in third or fourth intercostal space parasternally, left-sided. Here at 90 degree. And the position of index mark is at 10 o'clock. Clear? And we'll put this probe straighten up, that is at 90 degree. Another important thing is the position of patient while doing a 2D echography is left lateral. Clear? Now this is the anatomical view. We can see that we have put the probe here at third or fourth intercostal space parasternally, and index mark is here, that is at 10 o'clock position. We can see this is left atrium. We have left ventricle here. Separating the left atria and left ventricle is mitral valve or a bicuspid valve. We have this right ventricle here. This is LVOT, that is left ventricle outflow tract. And then we have this aorta here. Okay. So this is how the anatomical structures will look in a parasternal long axis view. We can also see interventricular septum here and posterior wall here. Behind the posterior wall, there is this pericardium. This is an anatomical view. Now this is the echo view showing parasternal long axis view. In this is left atrium. This wall is mitral wall. And we have this left ventricular cavity. The structure attached to this leaflet of mitral wall, this is papillary muscle. We have this LVOT, that is left ventricular outflow tract. Here we have this aortic wall, and then we have aorta going. Here this cavity is RV. Then we have this interventricular septum, posterior wall, and behind the posterior wall, this shining structure that is there is pericardium. This is how the anatomical structure will look in a parasternal long axis view, or we can call it as PLAX view. We can also increase the depth. So the structures we are seeing here, the same structure we are seeing here, but the depth here increase. We can also foreshorten this area to focus on some particular structure. So the characters of good PLAX view are that it should be straight. That is, the LA should be at 3 o'clock position, and aorta should be at 2 to 3 o'clock position. LV apex, which is here, should be at 9 to 10 o'clock position, and USG beam should be at right angle. So in this we can see this USG beam going, and this should be at 90 degree. Now PLAX view is quite important, as we have to measure certain structures and their length and diameter in PLAX view. At end diastole, we'll measure the diameter of interventricular septum, LV cavity diameter, and posterior wall diameter. So we'll pause the cardiac cycle in end diastole, like with this is in this view it is shown. Okay. Then we can measure the interventricular septum. We can also measure the LV cavity and posterior wall. And again, we can also measure the RV diameter from this view. So it is quite important that in this view, what are the structures that we can measure at end diastole, what are the structures that we can measure at end systole, and what are the structures that we can measure at mid systole. So at end diastole, we can measure the interventricular septum, we can measure the LV diameter, posterior wall, and RV diameter. So this is, here we can see the number labeled 3 is posterior wall. Measure label 2 is LV cavity. 1 is interventricular septum, and the number measured written as 4 is RV cavity. At end systole, we can measure LA diameter, and we have to measure LV diameter again at end systole, because LV diameter at diastole and LV diameter at systole both have to be measured to reduce the ejection fraction. Okay. So here one is, we have this paused PLAX view in which the heart is in systole phase. Okay. At end systole phase, so the number 1 which is labeled is LV at end systole, and the number measured as 1 here in this diagram is LA. Now the structures which are to be measured at mid systole is LVOT diameter. So we can see that here this is LVOT, just before the aortic wall. So we can measure LVOT here, and we can also measure aortic wall area. But aortic valve area cannot be measured directly. So to measure the aortic valve area, we use this continuity equation. That is A1, or area at LVOT, into VTI at LVOT, is equals to area of aortic valve into VTI at aortic valve. This we'll discuss when we'll discuss about advanced echo. Then at end diastole, we'll also measure the diameter of sinus of Valsalva and sinotubular structure. Okay. So we can see that this is aortic valve. Just after aortic valve, the aorta started, and this is the initial part of ascending aorta, that is sinus of Valsalva. Now we can modify this PLAX view according to our needs. So we can just place the probe one space up, that is if we have placed it in third ICS, then we can just shift it to second ICS to form high PLAX view. And this view is used to see the ascending aorta, and it is more commonly used to rule out aneurysm or dissection, or to look for the extent of dissection. Then we can also have this PLAX view with apical tilt. So this 2D echo probe, one movement in it is rotation. That is, the probe is placed here and we are moving the probe at its own axis just to change the location of index mark. This movement is called as rotation. Another movement that we have in the probe is tilting or angulation. So in PLAX view, we have already discussed that we have placed the probe at 90-degree angle. Now if we tilt the probe towards the apex, then we can have this apical PLAX view. That is, in apical PLAX view, we can also see this apex. Okay. So here we have this LA, mitral wall, LV, and LV apex can also be seen here. This is papillary muscle. Then we have this posterior wall. Then we have visceral pericardium and parietal pericardium. And between visceral parietal pericardium, we can see this fluid here. So this is pericardial effusion. So this is again a PLAX view. I have added a video here, but it is not working now. So we can see that this is LA. Again, this is mitral valve, LV, LVOT, aorta, and R. Okay. Now P-sex view. So for forming the P-sex view, we'll keep the probe at same intercostal space. Okay. But we'll rotate the probe. Angle would be again 90-degree, but we'll rotate the probe just to put the index mark at 1 o'clock position. So in PLAX view, the index mark was at 10 o'clock position. Now here we have the index mark at 1 o'clock position. The first view that is formed in P-sex view is aortic P-sex view. That is P-sex view at the level of aorta. Okay. So in this, we can see this aortic wall, which is opening into the aorta. Then we have this left atrium. This is right atrium, opening through this tricuspid wall into RV. We have this pulmonary wall, the area just before pulmonary wall is RVOT. Then and we have this pulmonary arteries dividing into right and left pulmonary artery. Okay. So here we have this echo view of P-sex view at aortic wall level. In the center we have this aortic wall. So from this view we can tell the morphology of the aortic wall, that is the aortic wall with bicuspid or tricuspid. Then we have this LA. We have this interatrial septum, RA, tricuspid wall, RVOT, pulmonary wall, and pulmonary artery. Okay. This is again a video of P6 which is not working. So LA, RA, RV, pulmonary wall. In the center we have aortic. This structure that is opening into the LA is pulmonary vein. So we have mostly 3 pulmonary veins opening into the LA. I just told you that we can foreshorten this angle just to focus on a particular structure. So in this P6 view at aortic level, if we want to focus on the tricuspid wall, then we will foreshorten this view. Now we have RA here, RV here, and this wall is tricuspid wall. We can also foreshorten this view towards the backside. So we have this aortic wall here. We have this LA here. Now we have this mitral short axis view, that is P6 view at the level of mitral wall. Okay. In this view, we'll keep the probe at the same point with the index mark at the same point. We'll just tilt the probe towards the apex. So you'll see this bicuspid mitral valve in the center. We have this interventricular septum here with RV behind it and LV cavity just below the mitral valve. Okay. And this is the best view to look for regional wall motion above. Again, this is the echo view, P6 view at mitral valve level. You can see this bicuspid mitral valve in between, interventricular septum here. This is RV cavity, LV cavity behind this mitral valve. In this was the video. Then this is a P6 view at the level of papillary muscles. So again, if we tilt the probe more, putting the probe at the same position, then we will having this P6 view at the level of papillary muscles, in which we can see this is the RV cavity, just like here. Okay. We have this interventricular septum, then we have this LV cavity, and we have this posterior and anterior papillary muscles. It's posterior medial papillary muscle and anterolateral papillary muscle. So this is a P6 view at papillary muscle level. This is RV cavity, this is LV cavity with posterior medial and anterolateral papillary muscle. This is also V. Now we have P6 view at LV apex level, which we will see this LV apex. This is just to look whether LV apex is empty or we have a thrombus in the LV apex. So in this we can see this is LV apex. Now we have this very important view, that is apical 4-chamber view, or we can also write it as A4C view. And this will lift the probe from 3rd intercostal space, put it in 5th intercostal space left side, just medial to mid-clavicular line, that is at the position of the apex beat. Index mark would be from 1 to 4 o'clock position. A good apical 4-chamber view is that in which all the chambers should be straight. Apex should be formed by LV apex and not by RV, and LV should not be foreshortened. That is, LV cavity should be quite good visible. So this is apical 4-chamber view. You can see the apex is being formed by LV. We have this LA here, RA here, LV and RV with mitral valve and tricuspid valve. So this is quite a good view to measure the ejection fraction by using the Simpson method. This is an echo view showing apical 4-chamber view. We have this LA, RA here with interatrial septum here, LV, RV here, with interventricular septum in between, along with mitral and tricuspid. So, as we have already discussed, a good 4-chamber view is in which all the chambers should be straight and apex should be formed by LV, and LV cavity should be clearly visible. So, we have this LV cavity, LV apex here, and all the 4 chambers are straight. Again, this for the video in which these are mitral and tricuspid wall, these are open. So, it is a diastolic phase. This is LV cavity arch. Then apical 5-chamber. This is a very important view for aortic stenosis. Okay? So we can measure the severity of aortic stenosis and the pressure gradient in this view. And in this view, we have this LA here, LV here, RA here, RV here, and this is aorta. These are the aortic wall. Okay? So this view is formed by the probe at the same position, but we'll just tilt the probe slightly towards the apex. How do we measure the severity of AS in this view is that we'll put a continuous wave Doppler at the level of aortic wall, and a graph like this is formed in which we can measure the Vmax. We can also measure the delta PG, that is pressure gradient, by using this continuous wave Doppler at the level of aortic wall using this 5-chamber view. So there are these continuous wave Doppler and pulse wave Doppler, and we have also the color Doppler that we'll discuss in the later sections. Now this is a echo view, is a apical 5-chamber view. Here we have this LA here, LV, RV, aorta, and aortic wall. So again a video. Then we have apical 2-chamber view. Okay. Just we'll keep the probe at the same position. Just we'll rotate it anti-clockwise to bring index mark to 1 o'clock position. Then we have this apical 2-chamber view. This can also be used to measure ejection fraction. We have this apical chamber view in which LA, LV, mitral wall. This is a pulmonary vein opening into LA. This is a echo view showing LA, mitral wall, LV, and this is a pulmonary vein. This was a video showing pulmonary vein LA, LV. We have a apical 3-chamber view in which LA, LV, and aorta are seen. The 3rd chamber is aorta. The probe would be the same position. We will further rotate it anti-clockwise from 2-chamber view to 10 o'clock position. So we have this LA, LV, mitral wall, and aorta. This is the view showing LA, LV, aorta, aortic wall. This is the 3-chamber. Again, this is a video. It was the video of 3-chamber view showing LA, LV, mitral wall, and this aortic wall and aorta. Now we have this suprasternal view in which probe is placed at suprasternal notch with marks on towards the head. So in this view, the anatomical structures would be seen like this. We have this ascending aorta, the branches of arch of aorta, and then we have this descending aorta. Okay, so this view is used to look for aortic dissection and for vascular abnormalities. This is a echo view showing suprasternal view in which we have this ascending aorta, this arch of aorta, and we have this descending aorta with these branches of arch of aorta, and right pulmonary artery. This was a video showing arch of aorta and branches of arch of aorta. So since the videos are not working, in the end I'll just open the PowerPoint presentation directly and will show you the videos. Then the last view that we have is subcostal view. Then subcostal view is put the probe 2 to 3 centimeter below the Ziffy sternum with index mark at 3 o'clock position. Then we have this subcostal view. This is also a modified apical, modified 4-chamber view in which we can see these all the 4 chambers. We have this LA, mitral valve LV, then RA, RV, and tricuspid valve. And we have this interventricular and interatrial septum. This is the echo view, LA, LV, mitral valve, RV, RA, tricuspid valve, interatrial and interventricular septum. So as the video. Then subcostal view can also be used to look for IVC when we tilt it. So we have this inferior vena cava and hepatic neck. These are opening into this area. So you can see this is the view. IVC, hepatic vein opening. We can measure the diameter of hepatic vein and IVC from here and check the compressibility and respiratory variation. So grossly we have these PLAX view, then we have this PSEX view at the level of aortic valve, mitral valve, papillary muscle and apex. Then we have this apical 4-chamber view, apical 5-chamber view, apical 3-chamber view, apical 2. We have suprasternal, subcostal. Basic views, basically we have these 3, 4, 5, 6, 7, 8 views. We have these 8 views. This ends our discussion. Now I'll show you the PPT directly to look for the videos. I hope it is visible now. Is it? Can I know that the slides are visible?
Yes, sir.
Thank you. So I'll show you the videos now. This is the first video, and this is showing this PLAX view. In this, we have LA at the upper end. This is LA. Then we have this mitral valve. Then we have this LV. The structure showing here is aortic valve, and this is aorta. Then we have this right ventricle behind this. We have this interventricular septum here, posterior wall here. Now we'll move to the next video. So this is a video of parasternal short axis view at the level of aortic valve. So we can see the structure in the middle is the aortic valve. You can also see the 3 cusps of the aortic valve here. And we have this structure which is LA. Then we have this structure which is RA, and tricuspid valve we have here. And the structure behind the tricuspid valve is RV. Okay. Again, I'll start the video. You can also see the pulmonary veins entering into the LA. This is the foreshortened P6 view at the level of aortic valve, focusing on the tricuspid valve mainly. Okay, it is clear now. The structure here is RA, and we have tricuspid valve opening into the RA. This is a video of P6 view at the level of mitral valve, in which we can see the mitral valve in between, interventricular septum here, and RV above. Again, P6 view at the level of mitral valve. Then this is the P6 view at the level of papillary muscles, in which we can see RV and LV contracting along with the contraction of the papillary muscles. This is P6 view at the level of LV apex, in which we can see that LV apex is clear, that is, there is no clot. This is apical 4-chamber view, in which LA is here, then we have LV, RA, and RV. We can also subjectively see that there is good contractility and the walls are moving freely. So definitely there are measurement criteria to look for ejection fraction and to look for valvular stenosis or regurgitation. But grossly, by looking at this apical 4-chamber view, we can see that walls are moving freely and contractility is good. Again, I'll start it. Now this is apical 5-chamber view, in which we will see the aorta also. So this is apical 5-chamber view. LA, LV, RA, RV, and aorta in between. Along with, we will see this aortic wall. And we have this apical 2-chamber view showing LA, LV, and focusing on mitral wall. Then we have this apical 3-chamber view showing LA, LV, and aorta, along with the aortic wall. You can also see the pulmonary veins opening into LA here. This is the suprasternal view showing aorta and its branches. Then we have this substernal or subcostal view, or we can also call it as subxiphoid view, which we can see this LA, LV, mitral wall, RA, RV, and tricuspid. And this is the view, subcostal view, to look for IVC, in which we can see the IVC and hepatic vein merging and opening into this RA. So thank you very much, guys. In upcoming classes, we'll discuss about different valvular heart disease and the echo findings in them.
So do we conclude the session? Arora, sir? It was indeed a comprehensive clinical class. The discussion was very useful to us. Thank you so much, sir, for teaching and guiding us. We're ever grateful to you. And we look forward to all your future sessions with White Army. It was all, we would also like to thank all the active members of this session. I hope you have a good day.